People who say this is graftless implantology, they're not really pointing to the right direction. There's no such a thing as graftless. The moment a tooth comes out, there's remodeling. Now, bone grafting is a big subject. Most people don't want to touch it because it can be a little bit complicated if you don't know where to start from, what to look for, and what kind of decisions you need to make to get it right. And it's not difficult. You just need to understand what it's all about and how to work around it. If we have 100 patients walking into a clinic with missing teeth from the posterior maxilla, probably almost half of them will not have enough bone to place an implant. What do we do in that case? Do we remove all the teeth and do a full arch? So we have to come up with something. We have a patient with diabetes who doesn't clean well, has lots of surgery. All that stuff put together will lead in a situation where the healing is going to take longer. There might be more complications during the healing. Whereas if we have a patient who has diabetes but is under control, who has very good oral hygiene, so we remove some parts of the stuff that create more oxidation, that will allow us to do the surgery and have much better healing. PRF is a biologic tool. It's not a magic wand. So if you do your technique in the right way, it can improve your outcomes, enhance the healing. But if you botch the surgery, it's not going to save your back. We know that the thickness of the Schneiderian membrane in healthy patients is less than 1 millimeter in thickness. In some cases, it's so thin that the moment you look at it, it ruptures. You don't even need to touch it. So in those cases, there is a technique that was popularized by Dr. Mike Picos, where you can use.
So I'm here with my friend, my very good friend, Stavros Eleftheriou. We've worked together for a few years now, Mr. Bone as he is called. And you know, we want to talk a little bit about bone grafting in general, but particularly with regards to the sinus. We've done a few cases together. I've learned a lot from you, and we want our sort of course delegates to learn the same thing. So maybe I thought it would be good to start off by talking a little bit about, you know, why does bone grafting have a place in today's implantology? With everybody talking about graftless solutions and various other ways of avoiding grafting, does bone grafting have a place in implantology?
Yeah, so I think people who say, you know, this is graftless implantology, they're not really pointing to the right direction. I mean, there's no such a thing. It's a misnomer. Why? Because we can do less grafting, so grafting less, because we've got all sorts of different types of site-specific implants, much better techniques nowadays, but there's no such a thing as graftless surgery. I mean, the moment a tooth comes out, there's remodeling. And within weeks, I mean, even 10, 12 weeks, the amount of bone you're left with is much, much less than what you started, especially at the front of the mouth where the buccal labial bone is very thin, most of the time less than 1 millimeter. So we also have a problem when it comes to the posterior area of the maxilla where we've got the sinus. And once a tooth is out, there's, the sinus becomes bigger, right? And we also have cases, we know, that patients have teeth where the roots protrude into the sinus. So once those teeth are gone, you know that there's much less bone in the area. Now, bone grafting is a big subject, and most people don't want to touch it because it can be a little bit complicated if you don't know where to start from, what to look for, and what kind of decisions you need to make to get it right. And it's not difficult. You just need to understand what it's all about and how to work around it. I mean, we talk a lot about implants, planning, different types of surfaces, different type of, platforms. Let's do this for this case, let's do that for that case, but we never talk much about grafting.
Is there a particular recipe that says this is the best graft material, or is it more dependent on the situation? Because I get a lot of people asking me, what's your favorite bone graft material, or what technique do you use? And I kind of say, well, it kind of depends on the case and lots of different variables. So on the course, do you give the delegates a little bit of insight into clinical decision making when it comes to grafting?
Well, I think that's a very important part of the course. Why? Because it's like you have to choose the right implant for the right indication. For example, you have an area where you only have 8 millimeters of bone. Obviously, you're going to choose the implant for that area. You have an area where you need to put an implant in an angle. You might choose to get an implant with a angulated platform like the Southern implant coaxis, or you need to use a multi-unit abutment, or you need a pterygoid implant with specific design characteristics, or zygomatic implant. Same with bone grafts. So it depends on why you need the bone graft. What is the plan once you put the bone graft and it heals? What is the plan? Do you want to place an implant in there, or just want to improve the shape of the bone in the area? Is it a case where you've got enough to put the implant in and just, improve the thickness of the area for longevity? And then it also depends on what kind of techniques you know, what you've been used to using. And most of the time I say, yes, use the techniques that you know best, but make some minor adjustments based on the biomaterial characteristics, what you expect that biomaterial to deliver, and if you do know how to handle the biomaterial. And you have to take into account how the body will react to the specific biomaterial you're going to be choosing. As we know, different biomaterials lead to different results based on how you handle them, but also how the body will react to them. And it's basic. Why? Because if we're going to be using autogenous bone, we know that it's the best thing to use. But autogenous bone, if not used properly, will not deliver the results. At the same time, most of the cases we do are quite straightforward and simple. And I don't see how I can justify in each and every case to go and take a piece of bone from the jaw and move it to a different part with screws and everything. I cannot justify that, since there's so many other things you can do and have the same or comparable results in a simpler way.
Could you share a little bit about your personal journey in terms of how you got into bone grafting, and what you learned worked really well and what you learned the hard way didn't work really well, and how has that sort of influenced what direction you've gone with your personal sort of choices?
My journey has been long and painful. I started, I was trained in oral and maxillofacial surgery, and I always loved the reconstructive part. So I loved big surgeries and resections and stuff like that, but I enjoyed much more building stuff. So I always loved the idea of replacing missing tissues with something. And when you're a max fac surgeon, the thing that you use 99% of the time is autogenous bone, right? But then I realized that there's other products you can use, and I started using, mainly in my private practice when it comes to implant dentistry, I started using all sorts of different materials, from bovine xenografts to equine xenograft to synthetic stuff to allografts to you name it. And I've realized that for specific cases, for example, where you have lots of bony walls and you have a cavity, whatever you throw into that cavity will heal. Now the question is, what do I want to get from that material? If I use, for example, an allograft or an autogenous bone graft into that cavity, I know for a fact that I'm going to get bone, native bone, after several months. If I use a xenograft, most xenografts will give me something that looks like an osteoid, and it's never organized bone. It's a white blob you see on the x-ray. You go back in after a few months or after several years and you still see a large percentage of that material still there. And if you're going to place an implant, you don't want that, because you want the highest bone to implant contact you can get. Now, synthetics, if it's a cavity, they work well most of the time in cavities. But then nowadays we've got xenografts, especially porcine xenografts, that are manufactured in a specific way that do deliver very similar results to allografts. And in the UK, unfortunately, and some other countries in the world, if a patient receives an allograft, that patient is not allowed to donate blood or organs. And as we know, most patients don't donate blood, or they're not planning to donate organs. But I get patients who say, yeah, what if a friend of mine or a relative wants an organ, wants blood? I want to be able to offer that. So nowadays, my main biomaterial is a porcine biomaterial for patients who have no problem receiving porcine, because in any case, even for patients who are a bit skeptical for religious reasons, it's not something that we consume. It goes into the body, yes, in specific area. It doesn't disperse out of that area. And it's replaced with our own bone with time. So that's my main biomaterial that I use, because I can have the same results as an allograft without having to receive bone from other areas. And I avoid the issues that I have with allograft in terms of blood donation and that kind of stuff.
So we hear a lot of people in bone grafting talking about, in my hands this works, and in Stavros's hands this works, and in Esteban Urban's hands this works.
Yeah.
What do you think are the variables that mean that something works better in one person's hands than in somebody else's? And on the course, are you going to talk about tips and tricks that people can employ to improve the outcomes that they're getting already?
So I think one of the things that happens is that people go to different courses, they learn a specific technique, and then they get confused. For example, you go to a course where they teach the GBR, the classical GBR technique, or the sausage technique, where you use a membrane and then you stuff it with biomaterial. And then you go to a course like a Curie technique. You learn the Curie technique where you receive a piece of bone and you do what you have to do and you fix it. And then they don't know, number one, which technique they should apply for which case, but they also try to combine things without understanding the very basics. And the very basics are very simple. If you don't have a cavity where you can just put your biomaterial to and allow to heal, you have to create that space and protect your biomaterial. You have to make sure that the bone granules are not going to be moving around, and that's very basic, because what happens, you've got the new blood vessel formation that goes through and between the granules, and every time you move that area, you destroy those blood vessels. So there's no nutrients, no oxygen, and that becomes fibrous tissue. And how do we know that? We know that from fractures. So we have two pieces of bone, fracture. We have to immobilize that. Why? We have to protect that blood clot that happens between the two fragments. And if that doesn't happen and they're mobile, they never fuse together and you get fibrous tissue. Same happens in a microscopic environment for a granule. So if you're going to be using a membrane, you have to contain those granules and make sure they're immobile. If you're going to be using Curie technique, you use a piece of cortical bone very thin for the same reason, to protect those granules. And then you have to take into account that you have to work a little bit on the soft tissue. So your suturing technique must be such that will immobilize the flaps, because we've got all sorts of muscles around the mouth. Every time we move, every time we sneeze, every time we smile, there's mobility. And we don't want lots of mobility over that area. Otherwise, we will end up in the same. So fibrous tissue, and then you don't get the expected results. So we're going to talk about the concepts. So you have to look at your defect and then decide if you want to build something around it that will protect the graft, and how to do that. And the idea is always to get the result, but in the most simplified way for the patient and for yourself. And I always say that the more techniques you know, the best, because you can choose the simplest and the least traumatic approach.
So how do you imagine the power of teaching with live patients will be when it comes to this sort of treatment?
So I was trained in oral and maxillofacial surgery in a hospital setting. And the idea was, okay, this is the case we're doing tomorrow, for example. You go home and you study, you learn the technique, you come in, I show you how it's done. The next case that comes up, you're going to do it, and me as an older surgeon, I will be helping you. So it's the see one, do one, teach one approach. This is how I was trained. So if you don't do it, you don't learn. So we always say you learn by doing. You don't learn by watching other people doing it. Yes, watching is great, watching other people doing it, because you understand the technique and how it should be done. But then if you don't put your hands in there, there's no way you will get that feeling, the feedback, where the difficulties are, what kind of questions you need to ask someone. Okay, I've tried that and it was a bit difficult. How do you do that? Why? Because it looks easy in your hands. Yes, I've been doing it for many years. I had the same problems with you. So you have to explain that to them. It's not like I was born doing it. No, I got taught how to do it. I've practiced it many times, and that's the way to do it. And if you don't do surgery under supervision, you don't learn to do surgery. We all know that. Because you make more mistakes, you feel helpless if there's an issue, whereas you always feel much more comfortable if you have someone that will, okay, deliver the theory, but also hold your hands for the first few cases.
100%. So I teach on a lot of all on X courses, a lot of people coming to learn how to
right, you guys, you and Reese run this lovely course
Absolutely.
in Dubai.
So we run a lot of courses on full arch, and that's kind of like become the sexy thing now in implantology is providing same day teeth, and you know, in many cases it's a wonderful treatment to be able to offer patients. We do notice a lot of people who sign up for these courses often have had very little experience of working around the sinus, and it's almost like they've gone straight from conventional axial implants straight into all on X, and I feel like sometimes they're lacking quite a large sort of skill set that you develop having placed single implants over a period of time, working around the sinus.
Yeah.
So could you tell us a little bit about some of the different techniques there are for sinus grafting or augmenting bone in the sinus region in order to be able to enhance conventional implantology skills before we start to go beyond that to try sort of extramaxillary techniques to avoid the sinus altogether?
So if we have 100 patients walking into a clinic with missing teeth from the posterior maxilla, probably almost half of them will not have enough bone to place an implant. And then what do we do in that case? Do we remove all the teeth and do a full arch?
Hopefully not. Yeah.
So we have to come up with something. And most of the time there is some bone there and we're missing a few millimeters of bone. And there are techniques which allow us to lift the sinus, minimally invasive, like the osseodensification technique, and place an implant at the same time, going through a very small osteotomy, the same size as the implant osteotomy that we would prepare otherwise. And that's very simple to do. It takes about 15-20 minutes to do that. The patients feel really good about it afterwards. There's minimal amount of pain, minimal amount of swelling and everything. And that is a technique that we're going to be teaching at this course. And then we also have cases where there's hardly any bone, 2, 1 millimeter or whatever. Much less often we see these cases, but these are the cases where we need to know how to do a lateral window approach to lift the sinus membrane, graft the area, put everything back, and then come back later on to place those implants. Now, this course will not only teach you these two techniques, and it will not only teach you how to diagnose and which technique is more appropriate for which patient, but also it will give you the skills that you can apply in cases where, for example, you take it a step further, pterygoid implants, maybe the sinus is a little bit in the way and you do a little small window, you lift the sinus floor and you put your pterygoid implant, or the so-called nasalis implant, right? Transsinus implant. So you go from the area, for example, of premolars and you want to engage the bone you have around the piriform area. Again, on occasion, you might decide, I need to do a small window to lift the sinus floor and get that implant in. Once you learn how to do the lateral window, it becomes so much simpler to do this technique. So in my head and in my mind, the progression should be, okay, I know how to do basic implants. I learn how to do some basic bone grafting. Then I need to consider, okay, a large number of these patients who come in, they need implants in the posterior maxilla where there's not enough bone. So what do? Do I refer them? Do I remove all the teeth and do a full arch? Or do I just do a little bit of grafting and put some implants? So I think it's very important for people who have just started their career in placing implants, they've placed a few dozens, a couple of hundreds, to take this course.
So we're going to be talking about lateral window or external sinus lifts We'll be talking about internal sinus lifts
Yes.
with osseodensification. Can you tell us a little bit about how the course is formatted, what the structure of the course is going to be?
Sure. So the first day is going to be lectures on basic anatomy, and I expect people who want to come on the course to just review their anatomy. So we don't need to spend much time there. We're going to talk about diagnosis, going to talk about the techniques on the first day, complications and how to treat them, what kind of medication we suggest that patients take, and when to refer the patient for a second opinion if there's any pathology in the sinus, etc. What kind of approach to choose based on what you see on your x-rays. And then on the second day, in the morning, we will be doing some model surgery, so both crestal osseodensification techniques and also the lateral window. And then afternoon is going to be the first surgical session. On the third day is going to be morning and afternoon session for surgery. And the fourth day, we're going to have another session of surgery in the morning. So we're going to have 8 delegates, hopefully. They're going to be working in pairs, and they're going to be working together to treat these cases under supervision. It's going to be me, and it's going to be other people helping around. So I'm going to be moving around rooms to make sure that everybody's happy and comfortable.
Fantastic.
Including the patients.
Of course, of course. And then, of course, the course is taking place in a fully functional clinic, very sort of high-tech dental clinic in Dubai. So those patients are going to be taken care of, prosthetically rehabilitated. And actually, it'll be our students who are learning how to place single implants and restore single implants that will be restoring those cases somewhere down the line. And then, of course, all the feedback will come back as to how those grafts have taken and all the scans and things, and tend to set up a closed sort of private group for the course delegates so they can follow up on their patients and see how everything's gone.
On that note, that's very interesting, because obviously feedback of what have I done here, did it work, I had this complication, I had that, what was the outcome? It's important for the delegates and for me, but also we have to let people know that there are places around the world where they offer this kind of procedures, but poor patients have to go back a week or 2 after the surgery, have the implants removed, because they have to offer those patients again to a cause that will happen several months later. That's not the plan in our cases. The patients have their implants, they're treated properly with respect, and once the course is done, other colleagues, dentists, will take over and finish the case.
Absolutely, yeah. So they're followed up, and they're very well looked after afterwards. Okay, so we've talked about the different techniques for sinus grafting. You see a lot of auxiliary techniques, such as using PRF and things like that. Are we going to be talking about these things, and what's your personal experience with these things, and how important is it for delegates to understand what things have a place in sinus grafting and what don't?
Right. So one of the things that I love to talk about, sometimes people find it boring, but I love it, is biology, and how biology relates to what we do in surgery, how we can utilize biology in order to get better outcomes. And we're going to be talking about a few things around this subject. We're going to be talking about oxidative stress. Basically, whatever happens in our body can create oxidants or antioxidants. And in an ideal world, we want a balance between the two. If we have a patient with lots of medical problems, we know that patient is in an oxidative stress, right? And in those cases, we have to take that into account, because our surgery will create more oxidation. So we either go and create a situation for the patient where we do stuff, or we suggest stuff that will reduce oxidation and do the surgery, and we can go and attack the patient in a nice way, of course. I mean, being more extensive in terms of surgery and without worrying, or we have to take it in smaller steps. Why? Because the more we push it, the more reaction we will have from the body, the less ideal healing we're going to have. For example, we have a patient with diabetes who doesn't clean well and has lots of surgery. All that stuff put together will lead in a situation where the healing is going to take longer. There might be more complications during the healing. Whereas if we have a patient who has diabetes but is under control, right, who who has very good oral hygiene, so we remove some parts of the stuff that create more oxidation, that will allow us to do the surgery and have much better healing. Where does PRF play into this? PRF is basically part of a clot. Nothing magic to it. It's part of a clot, but blood clot is what is needed to start the healing. Without a blood clot, there's no healing. I mean, dry sockets. What do we have? No clot, no healing, and we all know, unfortunately, how painful it is for the patients, and they actually need weeks until they heal. Very painful. You have to nurture those patients. So when there's no clot, there's necrosis, basically. So PRF is a clot. We can use it to our advantage and mix it with the biomaterials and have a more stable graft. But we also have an advantage because that PRF contains growth factors, which are responsible for angiogenesis, for the division of the right cells. It also functions almost like a decoy, calling all the right ingredients to come to the area. It's like any other clot, right? So we create a concentrate of that, and obviously the results are much, much better, especially during the first few phases of healing, which are the most important. The other thing that we can use, in terms of PRF, I mean, is you can use membranes, especially on the Schneiderian membrane, and they go and they stick on the membrane immediately, and even if you have a small rupture, you can, repair it without suturing, without any collagen membranes. Just put a layer of PRF membranes, that's done.
Does the job.
So PRF is a biologic tool. It's not a magic wand. So if you do your technique in the right way, it can improve your outcomes, it can enhance the healing, but if you botch the surgery, it's not going to save your back, right? Now, we will also discuss the way the immune system can help or make things worse. So whatever we do in the body, like an incision, an extraction, a bone graft, an implant, we have the immune system going and checking what's going on. If the immune system is not happy with the materials that we've used because they're not friendly to the body, it will react, right? It always reacts, but the more friendly our techniques are, the more biologic sense there is to what we do, the less reaction we have from the immune system, and that means less inflammation, less problems. So I just want to remind us how we ended up having this clean implant foundation. In the past, there was many companies, implant companies, that would prepare their implants, package them, sterilize them, but there was lots of remnants from the manufacturing process. And those remnants would lead to reaction from the immune system, not immediately, but sometimes after a year or two, and we would lose implants without understanding what was going on. And it's just a case of the immune system doing its job, because the immune system never stops checking the area. It goes back again and again and again. And if it finds something that it's not happy with, it starts creating inflammation. So we have to take that into account, not only when it comes to the techniques, but the biomaterials of choice. Because some biomaterials are very, very similar to the human bone, and the immune system checks them and says, oh yeah, it's probably our stuff, no problem. But if the biomaterial has characteristics which are very different to what the human bone is, then it will react.
Fantastic. So sinus grafts, there's never two sinuses that are the same. No two patients that are the same. We've got so many patients with histories of ENT problems, smokers or ex-smokers. How do our delegates learn how to, first of all, diagnose which techniques are the most appropriate? And what kind of complications have you come across in your experience that you can help to train our delegates in to avoid? Because I think for people who don't do large volumes of sinus work, they may not have come across some of these complications before. So how would you share that?
So the first step is a good history and CBCT scan. When I say good history, we have to make sure that we know if that patient has had sinus issues in the past, sinus surgeries in the past, and if there's any ongoing situation. Because if we do know from the get-go that the patient has had surgeries, we do know that generally speaking there's a higher percentage of sinus-related infections and all sorts of other problems after doing extensive sinus surgery for grafting and implants. So in those cases, I make sure that, you know, whatever happened in the past is more or less in the past and is under control, and the patient is under supervision, I mean, from the GP or ENT or whatever. And if I have to do a sinus lift, I would try and do as minimally invasive of a procedure as possible. And even in cases where I've got some bone and I can engage an implant and do the sinus lift at the same time, I might choose to do just the bone graft, allow everything to settle down, and then come back and do, you know, a simple implant placement. The other thing is that CBCT scans. So if I pick up 1,000 people from the street and do CBCT scans, about 60% of those people will have some thickening of the Schneiderian membrane. If the thickening is more or less the same throughout the sinus, not a problem, and we're not talking about 10 and 15 millimeters of thickening. A bit of thickness of the sinus, a good aeration, is not a problem to do a sinus lift when you know what you're doing. We need also to check what's going on with the osteomeatal complex, because we need to make sure that that is potent and there's good aeration, because if it's not potent, then the patient needs to go to an ENT and be seen by a specialist who deals with that kind of stuff. If we see any irregularities in the sinus in terms of what we expect to see, thin soft tissue, and we have some areas which is thick, some areas which is thin, if we see osteopathies, if we see areas where the bone is rotting, let's put it simply, so we need to make sure that those patients are seen as soon as, right? So if we only have, you know, a sinus which is well aerated, a bit of thickness of the Schneiderian membrane, no symptoms, that's important, then most of the time we're good to go. We're going to be looking at x-rays, we're going to be discussing cases, and then the other thing we need to make sure that we know of is if we have septa in the sinuses, because we have to address them in a specific way. We need to see if we have sloping sinuses. Also, another thing we have to address in a specific way. And these are things that we're going to be discussing. Now, the most frequent complication we have with sinus lifts, once we make sure that the patient is generally healthy, the sinus is generally okay to have surgery, the most frequent complication is the rupture of the Schneiderian membrane. And we know that the thickness of the Schneiderian membrane in healthy patients is less than 1 millimeter in thickness. And in some cases, it's so thin that the moment you look at it, it ruptures. You don't even need to touch it. So in those cases, there is a technique that was popularized by Dr. Mike Picos, where you can use a membrane, you create almost like a pouch, right, inside the sinus, and you have to tack that membrane, and you can graft that, and you can get on with life. And 90 or more % of the time, you get lots of bone, easy to deal with it. It doesn't happen often, because most of the time, we will end up with a rupture, you can cover it either with a PRF clot or a collagen membrane, or by lifting the Schneiderian membrane, the membrane will fold on itself, and that goes away as a problem. So back in the day, many years ago, if we would be looking at the literature, most people were talking about 50% of, rupture of the membrane, 30%. Nowadays, about 20% of the rupture is an accepted complication, in terms of number. For the lateral window technique, because when it comes to the crestal techniques, especially with osteodensification, it's between 8 to 12%. So it's even safer if you can, and if you have the right amount of native vertical bone, to go with the crestal technique.
Certainly the crestal technique, or the sort of the internal lift, has now become, much more popular. I was quite lucky to train with Hilt Tatum back in the day, when a lot of people have claimed to being the first person to lift the sinus internally. The Summers lift, the classic Summers lift. So it's been around for a while, but in the past we used to use osteotomes, and then there were other techniques that became sort of popular, and now the latest, it's not recent, but certainly osteodensification has become a lot more popular. But I still feel like a lot of people don't have confidence with it. They're worried, particularly in the sort of more extreme cases when there's maybe less than 4 or 5 millimeters of bone. So is this something that we're going to go into detail on in the course, and how confident will the delegates be after to go home and do it themselves?
So when it comes to osteodensification, there's 3 different protocols depending on how much bone you have to start with. The 2 most popular protocols, which are for cases where you've got up to, I don't know, 4 millimeters of bone minimum, are already on the internet. Everybody can find them and have access to them and try and apply them, but there are a few tricks of the trade, and this is the things that we teach at the osteodensification course. And my suggestion is people who want to come on the course will benefit a lot by attending the official osteodensification course. Some of them have, but they don't know the technique. They're not comfortable doing it because maybe they missed bits and bobs from the course. Maybe they've done the course, but they haven't tried it, and it's a bit rusty in their mind. But we're going to go into detail. I will explain how it's done. We'll do it on the models, and then we're also going to be doing it on the patients. It's a much safer technique. It offers the options of even using them in cases where you have a septum or a slopey sinus, no problems. And you don't have to worry about, using a hammer, which patients hate. And we have very little control over that. With a rotating instrument, once you understand how it's done, we have loads of control. So it becomes much easier to do, and you can also graft as much as you need. There's no situation where you can say, it's osteotoma can only graft by a few millimeters. If you want to graft 5 millimeters, need to graft 5 millimeters, you graft 5. If you need to graft 10, you can graft 10. I don't think there's a case where you need to graft 10 most of the time, but it's possible to do whatever you want.
That's great.
Yeah.